So I'm going to talk about an international study called the PDOPPS study. It's a study that I was at a Canadian Society of Nephrology meeting, hearing all this hemodialysis stuff, catheters and phosphate, and I said, well, why has nobody ever approached the DOPPS group to look at a study in peritoneal dialysis? Aren't we important? Aren't our practices variable? And after lots of years and lots of hard work, and some people in this room help and collaboration, the peritoneal dialysis outcomes and practice pattern study is starting. So I wanted to give you all an update on the PDOPPS study and open it to questions and comments and hopefully generate a discussion. So the PDOPPS study is really unique because the main coordinating center is Arbor Research, which really has coordinated the hemodialysis study since 1996. What's different about the PDOPPS study is it's a collaboration with the International Society of Peritoneal Dialysis. So really the two groups came together to make this study happen. And this is our Ontario team. I recently met, and some of these are the physicians and coordinators across the sites in Ontario. I'm hoping today we can get a picture here of some of the people working in Quebec. And I just want to thank the supporters of PDOPPS. Our main industry sponsor has been Baxter Healthcare, really that has helped set up the central funding for the study. Fresenius Medical Care has contributed as well, but it really relies on local funds to support data collection in different countries. So when Japan, the Japanese Society for Peritoneal Dialysis has funded the study, we were lucky to get funding from the Canadian Institute of Health Research, and recently in Australia they received funding through a similar peer-reviewed funding body to support data collection in Australia. So these are my disclosures, and I thought today what we'd do is talk about the reasons why people leave PD therapy. We'll talk about what the trends are in PD technique failure in Canada. So the big question that I had was, is technique failure improving in Canada? Is it decreasing, or is it about the same? And we'll talk about that. And then we'll talk a little bit about things in the literature that have come out of the literature as some specific risk factors for technique failure. And then lastly, we'll talk about the PDOPPS study. So I don't have to tell you here in Quebec, and I think this is a similar story across all provinces, but this is the dialysis population that we're treating, and this is new dialysis patients in Canada in the rate per million. Now, interestingly, this is kind of, if we look out to 2014, it's flattened off a little bit, but we are dialyzing a predominantly elderly patient population. That's going to be important for the second talk that I give you this afternoon, but it's really important for us to think about that, because I just want to step back and say it's not all about survival, it's also about quality of life. And a lot of these patients probably would have very limited survival whether they were on dialysis or not, but are probably more concerned with what their quality of life is. And we all heard through the last talk about some of the cost benefits of home dialysis. And if you look at the costs of peritoneal dialysis versus hemodialysis, it's a much more cost-effective therapy. And this is some costing data from Canada. So you can see a huge decrease from in-center costs to peritoneal dialysis costs. So the whole premise is that perhaps peritoneal dialysis might be a very viable option for our elderly dialysis patients. And if costs are lower, what about outcomes? Well, one of the things is survival in PD versus hemo. And when you look at patients who dialyze with a catheter, patients who dialyze with a fistula or graft in PD, and you really have a level playing field of people with what I call optimal access, survival is really very similar between the two therapies. So, just a plug for why we want to look at PD is it's a therapy that's cost-effective, it's a therapy that's associated with similar outcomes to in-center hemodialysis, and we can deliver it at a much lower cost. But, this is the problem here in Canada. If you look at new dialysis patients in Canada, in the 1990s, we were at around 30%, and we've had a steady and slow decline. And right now, there's really flat growth in the number of new dialysis patients in Canada. And if you look at how we increase PD utilization, one of our goals here, and many of you here today clearly are supportive and are a community of people who believe in some of the merits of home dialysis, and if one of the strategies is to grow home dialysis, it's really a very simple formula. We either put more patients on the therapy right over here, or we have them on the therapy longer. And so, one of the ways that you can increase the utilization of PD is not to change the number of new patients on the therapy, but to extend the time that patients are on the therapy. As much as you try to increase PD utilization by increasing the number of patients on the therapy, if that's going to come at an overall decrease at the time on PD, all of our efforts to increase incident peritoneal dialysis utilization will really not necessarily lead to increasing the use of PD. So we really need to understand this, and we need to understand what the drivers are of PD utilization. So I think what the PDOPPS study is going to do is really focus on time on PD. We've done a lot of studies and we have a lot of literature around some of the strategies to get new patients on, but what about keeping the patients that we have on the therapy longer, healthier, with a better quality of life? And that's really a lot of the focus of the PDOPPS study. Money makes the world go round, and it's really interesting here because in the United States, many of you may not be aware of this, but they've bundled dialysis care. So they give one payment to the providers of dialysis, whether it's PD or hemo. And we've come to realize that you can deliver PD at a much lower cost than hemo and achieve similar outcomes. Well, before, reimbursement used to be made on the basis of injectable medications that were given to hemodialysis patients, and they've gotten rid of that. They said, here's one payment for PD, here's the same payment for hemo. And what I think is a very interesting time right now is we're going to see PD in the United States increase significantly. So already based on some early data, when the bundling started to happen, we're starting to see increases in home dialysis use in the United States. Now, what does that mean? That means a lot of inexperienced new centers are going to put patients on peritoneal dialysis who never had considered peritoneal dialysis before. And what is that going to do to overall technique survival on peritoneal dialysis in the United States? And I think it'll be a very interesting story that we'll see evolve. And again, this is just a recent paper from AJKD now. A first-year PD patient in the USA, a first-year dialysis patient rather, in the USA is 42% more likely to be treated with PD in 2011 than 2007. So there's, with this change in reimbursement, we're starting to see much greater utilization of peritoneal dialysis in the United States. So it's a very opportune time to look at technique survival on peritoneal dialysis. So, there's going to be this uptake by novice facilities. There's going to be uptake among underrepresented patient groups in the United States, or both. And the United States has been criticized for very much cherry-picking PD patients to be the healthiest of patients. So it'll be very interesting in the United States to see what the effect of all of these changes are going to be on technique survival. And if you look at outcomes for incident patients, these are patients that are on PD, and really there's only 4 ways to leave peritoneal dialysis. You can have a modality change to hemodialysis, you can die, get a kidney transplant, or a very small proportion of patients who recover kidney function. That's it. Once you start PD, those are your 4 options. And nobody would argue that technique survival compromised by very high transplantation rates would be, something that we wouldn't strive for. We would be more than thrilled if all of our patients who were eligible transplant candidates could get transplanted and we could shorten the average time on peritoneal dialysis therapy. And that's probably more of an important way to look at it if you're actually an administrator or looking at your PD program. But some PD programs tell me we can't grow because we have such a high transplantation rate. And I say, damn, I wish that was the problem in my program. And so it's important to know that. But really, when we're looking at technique failure as a quality improvement metric, we really need to focus on things that are potentially modifiable, modality changes and death. And the other thing that we have to think about is, well, none of us want to keep patients on PD longer if it's going to adversely affect their mortality, right? So, there may be an optimal time of PD where we're not compromising mortality. And that's why it's always important to think of these two, modality changes and death, together as one entity, because we certainly have to think about it that way. So, this is, when we first started to think about the PDOPPS study, one of the challenges I had was, what's the definition of technique failure? Is there any definition out there that we can capture and use and move forward with this study? And when you look in the literature of what people have studied and called technique failure, it's quite variable. And I've seen definitions like any PD related complication that leads to the permanent cessation of therapy. And then the question is, well, when does PD begin? What is day 0 of PD? And it's been defined so differently across so many different studies. And as I mentioned, should it include both death and a change in modality? Because we don't want to study just time on therapy without completely ignoring the issue of deaths. And what does permanent mean? So what's a permanent transfer to hemodialysis? And these are some questions. I don't know that I necessarily have the answers, but you have to be aware about that when you read literature around technique survival on peritoneal dialysis. And you know, if we look at when PD begins, there's this huge bottleneck here, you know, and there's certainly very significant bottlenecks that affect PD utilization and very early on are early causes of technique failure. So let's go through a thought experiment here, and let's say PD begins when the peritoneal dialysis catheter gets inserted and there's an intention to perform peritoneal dialysis. So this is a study that we did, about 3,900 patients who chose PD and underwent PD catheter insertion in Ontario between 2000 and 2010. And only of these catheter insertions, only 83% of patients actually made it to get 4 full weeks of PD. That means that there is a 17% drop-off from PD catheter insertion to peritoneal dialysis. And so 5% of these patients either died or didn't get any dialysis and follow-up. Maybe they didn't need dialysis, but about 12% who had a PD catheter inserted underwent hemodialysis. And that really tells us when you're looking at PD utilization, all these registries, they're already biased because the people had to make it to PD to get called PD patients. But you know, there's a tremendous drop-off even from the time of catheter insertion to the intention to perform PD. And should we be thinking about that? And should we be studying some of the factors that affect technique survival very early on, which is something that hasn't been looked at quite a bit. And so this is one challenge. And again, if you look at a more detailed group, this is data from Matt Oliver, where in a subset of patients, we collected much more detailed data, about 169 patients who chose PD. 7 patients had a failed attempt, so there was an attempt to insert a catheter that wasn't successful. 5 patients chose hemodialysis after PD catheter insertion. 1 had a hernia during training and was unable to complete training. 2 had PD catheter leaks. 1 had early exit site infection, and 2 had primary PD catheter malfunction. So again, among these 169 patients, 87% received PD therapy. And that's important for us to know and track because it's a very early bottleneck that patients don't make it to peritoneal dialysis at home because of all of these early complications. So should we include that in our definition of technique failure? Is it something distinct that we need to study? We've chosen to, in the PDOPPS study, to avoid using these definitions and including these because it's very hard to track patients who have catheter insertions all over the province and all over the facility. So for the DOPPS definition, PD is your first peritoneal dialysis therapy at home, independent of the facility. But I just mentioned this because there's a lot of important stuff happening even before that moment that we need to understand and study. And if you look at why patients change modalities, this is a pie graph from the United States. It's rather old and hasn't been updated, but everybody blames peritonitis, right? If you ask anybody, what's the #1 cause of TD technique failure? Peritonitis. But you know what? It's not winning by a large amount. It's not like, you know, you look at this picture and you say, whoa, peritonitis is really a big problem. Peritonitis is one slice of this pizza. But there's all sorts of things going on over here. There's catheter problems, there's inadequate dialysis, and I don't even understand what is the definition of inadequate dialysis. And we had to struggle with that in the PDOPPS study. And then there's psychosocial causes, which again are very poorly understood. And then this huge pizza pie of other. So other is not a little minority here that we can't categorize. Other is a very big component of this. And again, if we have to understand technique failure, we need to be able to define it, we need to be able to categorize it, and we need to be able to make sense out of it. And again, is it better in Australia? Well, no. Again, infection here is a leading cause. But what I find very interesting is look at the issue of psychosocial causes. It's huge. In fact, I was just recently in Australia 3 weeks ago, and I said to them, what is going on here with psychosocial causes of technique failure? And I think it may just be that they're ascertaining it in a lot more detail than we are or in the United States. But this is a big issue. And again, it's very hard to understand what's meant by psychosocial causes of technique failure. And again, inadequate dialysis, technique failure, and infection. But again, different definitions. We're comparing apples and oranges between countries. And it's important to think about what a PD patient in the first year of therapy may be at risk for different complications and different reasons for technique failure than a PD patient who's been on PD for 3 or 4 or 5 years. And so, again, this is just a Dutch study that I point out only to mention that, as you would understand or make sense, you know, catheter problems tend to happen early, within the first 3 months of PD therapy. Infections tend to happen over the course of time. So a patient on PD, whether it's early, late, is always going to be at risk for peritonitis as a cause of technique failure. As you'd imagine, under dialysis and ultrafiltration failure tends to worsen over time, because we heard an elegant presentation this morning about some of the changes of the peritoneal membrane on time on therapy and how that impacts under dialysis. But I just wanted to point this slide out because we have to think about different reasons at different times, and different patient groups may be affected by technique failure reasons at different times, which is why in the PDOPPS study we have a group of new patients that we're capturing data on, but we're also trying to recruit prevalent patients, because what affects a patient who's been on PD for 1 or 2 or 3 years might be very different than what affects an early PD patient. And you know, peritonitis. So, okay, we all think that we can categorize peritonitis. We have an ISPD definition. You know, peritonitis is something that I think is ascertained fairly well across programs. But why does technique failure happen after peritonitis, right? So one of the things is it's a marker of non-adherence to therapy. So this patient has a second coagulase negative staph peritonitis. I don't think they should do peritoneal dialysis therapy. There's nothing wrong with their membrane. They've cleared the episode. But psychosocially, we think that there's something about that peritonitis that might be a marker that they're no longer able to do therapy. It may just be a marker of functional decline or increased comorbidity. And the peritonitis just might be telling us, well, this patient might be very sick and have a lot of other illnesses. And this is like sort of the last straw on the camel's back where the patient needs to transfer to hemodialysis. Sometimes peritonitis can lead to changes in the peritoneal membrane that make it difficult to move forward with PD. And again, after the 3rd or 4th or 5th year on PD, if someone gets a peritonitis, what that's going to do to the peritoneal membrane may be very different than a patient who gets early peritonitis. A lot of the times patients have a peritonitis and they never want to have another episode, and the only way to guarantee that they never have another episode of peritonitis is to take them off the therapy. So it may be the patient that's driving patients off peritonitis. It may be the patients that are driving the decision to go off peritoneal dialysis onto hemodialysis. And these are all situations where theoretically one could continue with PD medically. And you know, these are the classic things where we think about the medical need to remove the catheter for resolution. So if there's an exit site infection, if there's a fungal peritonitis, a recurrent or repeat episode, somebody who's not responding to treatment. But then again, it gets even more complicated because some of us may be bringing those patients back and they may only be on hemodialysis temporarily. So then there's a whole other set of decision making that happens. Well, is this transition to hemodialysis going to be temporary or permanent? Sometimes the patient drives that decision, sometimes the physician drives that decision, and sometimes the system drives that decision. So who here has had a patient where you intended to put them on temporary hemodialysis and it ultimately became permanent? Exactly. Or who here has had a permanent transfer to hemodialysis where the patient begged you to come back and it was only temporary? Exactly. So you have to see that then a decision happens even after patients get transferred to hemodialysis. So again, we had to think about if a patient was temporary, how long are we going to use that definition of temporary? Because people come back and people change their minds. And sometimes it's the right decision because the patient realizes they felt a lot better or there may have been other problems. But again, these all drive peritonitis-related technique failure, and we need to be aware of them. And then what about psychosocial causes of modality change? So this one is, in my mind, what I call a black box, because you could take anything and throw that into the psychosocial category, because we really don't understand that. And you know, this is my way of looking at it, but I'm open to other definitions. But one is, you know, situations where you can't perform self-care dialysis. This might be comorbidities, the loss of a caregiver or caregiver burnout, somebody who's changed their living condition, who is living in a place now that doesn't support home therapy where it did before, somebody whose functional and cognitive status has changed. And we need to capture that information. We need to understand how much of technique failure is being driven by that, and maybe the talk in the afternoon will address some of these issues. And also, it might just be patient preference. So again, we really don't understand a lot about patient preference. It may be playing a role in other causes of modality switch. So it may be peritonitis, and the patient was offered to come back to PD, but didn't want to. Well, that's important to know. It may be patient burnout, and again, it may be it's very poorly understood. So I think what we need to do is take this big psychosocial box and understand it a little bit more. So how do we do in Canada of categorizing peritonitis-related, peritoneal dialysis-related technique failure? Really poorly. And you know, there's three categories in core that make any sense to me. There's inadequate PD, which is, again, a loose definition. Is that salt and water removal? Is that KT over V? Is that the phosphorus was too high? Who knows what people put down when they write inadequate PD? I really don't know. Peritonitis we talked about, probably easily ascertained. And then there's like a million other causes that make no sense or have no order to me that are categorized. And I just couldn't make sense of them, so we had to loop them all together. And it's not peritonitis that's changing. It's not inadequate PD that's changing over time. It's all these other causes. So the question is, what is going up? What are these other causes that are going up? And we need to understand that. So let's look at what's been happening to technique failure in Canada. So we'd all like to pat ourselves on the back and say, we have all these fancy new peritoneal dialysis solutions in our armamentarium to use. We have much lower guidelines for small solute clearance than we ever had before. KT over V targets for PD have gone down and down and down. We have improvement in peritonitis prevention strategies. We have good PD connectology. Most units are now using some form of prophylactic antibiotics at the exit site. So what's happened to time on PD therapy in Canada? With all of this, we should be seeing better improvements in PD technique survival. And you know, if you look at peritonitis rates in Canada have been decreasing. This is data from Sharon Nessim, who did her master's project on peritonitis-related outcomes, and she's at the Jewish General Hospital. And again, you can see here that peritonitis rates over time, according to her data, using the Baxter POET database software, where all centers that participated in POET were aggregated together, had been decreasing in the late 90s to the early 2000s. Similarly, this is data from Australia, again showing you that peritonitis rates are decreasing. So there is an impact of some of these strategies on peritonitis. But what's been happening to technique failure? Well, we have to understand, and this is how I sort of open the argument, that patients can either change modality, die, or get transplanted. Who do we transplant? Our healthiest patients, our youngest patients, our patients with fewer comorbidities. And who tends to die? Our oldest patients, our patients with more comorbidities. And so when you censor patients and you look at technique failure as an event, you're censoring patients, but the patients you're censoring, they're telling you they're being censored for a reason that we call informative, meaning the reason they're being censored, you may be selectively removing the healthiest and the sickest patients from your cohort. So that's why whenever you read the literature and see death-censored technique failure, you have to be weary about that. You don't want to censor death because those patients died. And if they were alive, if so to speak, they may have been the ones with the worst technique failure. And if you were a program and you said, we're not transplanting any of our patients, that program may have longer technique survival because you're keeping in the cohort patients who you don't transplant. A good example of that is in Japan. Why does Japan have such a high incidence of EPS? Because they have very, very low kidney transplantation rates, so patients stay on PD longer and can develop EPS. So you need to take into account competing risks of transplantation and death. And so what we did is not to death censor. We actually did a competing risk analysis. So this is just explaining what I told you, that death and transplantation are always what we call competing risks when you look at technique failure. And so we did what was called a competing risk analysis. And again, that's going to be impacted if you're looking over time. If the transplant rate over time is going down, you may be making technique failure look longer, right? Because you're not transplanting patients now and you used to. If the death rate is going down, again, technique failure may be longer because of a changing death rate. So you need to take into account the death rate, the transplant rate, and the technique failure rate. So this is 1995 all the way to 2008. And what you can see here is that the transplant rate actually hasn't gone down as much as you'd think. We all hear about the wait list for organs and deceased donor transplantation, and some of that might be greater living donor transplantation. The other might be the acceptance of more marginal donors than we used to accept. So that's not changing, but the death rate is going down dramatically. So you can see here that patients are dying at a lot lower rate than they had been in the early 90s. And this is true on both PD and hemo, but this is just new PD patients. And this is the technique failure rate, looking at a year. Now, this might be a little complicated. This is the year that the patient started therapy, not the year that they experienced the event. And again, when you look at that, you can see that, again, patients over the age of 75 in Canada are getting a greater proportion than they used to be. We're dialyzing more patients with diabetes, and we're dialyzing bigger patients than we have before. So we need to think about this data in the context of the landscape of our dialysis patients changing over time. And again, when you look at the risk of transfer to hemodialysis among patients in Canada, it really hasn't changed a lot in the last 15 years. This is the group who started dialysis between 1995 to 2000. This is the group that started between 2001 to 5. And this is the group that started between 2006 to 9. And you can see here maybe a little improvement over here, but no real improvement in 2006 to 2009 patients compared to these early patients. And what about death? Well, death has been progressively improving over time. So really, we haven't had or haven't changed technique survival on PD very much in the last 15 years. And again, what's the average time or median time to modality change among patients? The median time on PD in 1994 to 2000 was 1.9 years. The median time in 2001 to 5 was 2.2 years, and now 1.7 years. So again, we really haven't been able to really make a big dent in time on therapy from this 2-year mark. What about peritonitis? So I told you that peritonitis rates were improving over time. What's been happening to peritonitis-related technique failure? Nothing. So you can see here that the rates of a transfer to PD, from PD to hemo due to peritonitis has not changed at all since 1995 to 2000. If anything, there's a trend for more transfers due to peritonitis in more recent eras. So again, we haven't been impacting technique failure due to peritonitis. This is interesting, and if you look at related to modality switches related to inadequate dialysis, initially here in 2001 to 5, there were greater modality switches compared to patients who started in 1995 to 2000 due to inadequate dialysis, but in this most recent cohort, a lot lower rates of transfer due to inadequate dialysis, and we'll talk about that. The good thing is that what you can do with Canadian data, this is the Canadian registry data, is when you have thousands of patients, you can start to look at different subgroups. Is this true in diabetics? Is this true in non-diabetics? Is this true in older people? Is this true in younger people? And so when you slice the data to patients over the age of 65 or patients under the age of 65, in fact, there has been some improvements, and the biggest group that's had improvements have been patients over the age of 65. So again, at least in as much as if you think back to the first slide, the patients we're treating are those over the age of 75. Older people traditionally have been reported to have poorer outcomes on PD, but their outcomes seem to be improving over time. So I think that's good news, considering that older patients, and maybe the definition of older should be older, but that older patients are actually doing much better on PD than they used to. But the overall summary is that there's really no improvement in the rates of modality change from PD over time. The exception I mentioned was patients over the age of 65, but there has been an improvement in patient survival. There's been no change in the rates of technique failure due to peritonitis. And initially, there was a blip in more transfers due to inadequate dialysis and a recent decrease. And I think that might be explained by following up on guidelines. I think that we're now starting to realize that we don't need to dialyze our patients to these high KT over V targets. And now the total KT over V target of 1.7 per week has meant that patients who would have been taken off the therapy because they weren't meeting adequacy targets probably are kept on now because of the guidelines. But this, I think, is the most interesting. There's globally improving peritonitis rates, but there's really been no change in peritonitis-related technique failure. So you could say, okay, well, we now take the catheter out in more patients than we used to, and we used to leave the catheter in. But I really don't know if I buy that. I think, if you think about it, if the catheter has to come out, it has to come out. I don't think we didn't take the catheter out before when it needed to, but that's one possible explanation. The other thing is, although we're reducing peritonitis rates as a whole, we may not be having as big an impact on the peritonitis episodes that lead to technique failure. So we may be, all of our technology really, if you think about it, has been focused about reducing skin bug and catheter-related peritonitis. We haven't had as much technological advances in reducing enteric peritonitis in other organisms. And I'll show you that. So this is the percent of peritonitis episodes by organism. Clearly the big winner here is coagulase negative staph. When you look at all peritonitis episodes, that's really the one that is the key player. But again, if you look at the outcomes of peritonitis by organism, coagulase negative staph has a very low percentage of technique failure. Gram negatives have a much higher, fungal clearly have a very high rate, and Staph aureus and Pseudomonas, which is not here. So one of the things that might be happening is we might be, and we don't know this is what the PDOPPS study will help tell us, is are we shifting the microbiology of peritonitis? Is what we're seeing leading to technique failure more the gram negatives, more of the difficult to treat bugs, and we have done a very good job at preventing the bugs that we wouldn't have thought of would lead to technique failure. So it really isn't mediated by a reduction in peritonitis-related technique failure. Or due to inadequate PD, the whole issue about elderly patients. Elderly patients are the largest growing segment of the dialysis population. And again, I'm just speculating, but it might be that we're really increasing the use of home-assisted PD patients across several regions in Canada. So this is a good segue into the talk in the afternoon, that at least patients over the age of 65 are doing better on PD than they've done before, and that might be the support that we have in place for them. So that's really what's happening in technique failure in Canada. And when we look at why patients transfer, there's always factors at the patient level, therapy-related factors, and facility-level factors. And just said simply, age always comes out across all registries as a risk factor for technique failure. Again, gender. Females consistently tend to do better on peritoneal dialysis in terms of technique survival relative to males, and it's consistent across US, Canadian, and French registries. Diabetes always comes out as a risk factor for technique failure, and ethnicity. Clearly, Aboriginals have a high risk of technique failure here in Canada, and Black patients in the United States, and that might be some socioeconomic factors. Body mass index, so the larger the patients, the greater the risk of technique failure. This is Australian data, again similar in Canada. The greater the BMI, the greater the risk of technique failure. And that might be mediated by a higher risk of peritonitis. It might be mediated by inadequate dialysis. We really don't know why. This is looking at a little bit of socioeconomic factors. This is actually data from the United States. Again, if you look, or data from Canada, Ontario actually, if you look at neighborhood education level, less than high school, a greater risk of technique failure. So this is where the patient lived. A greater risk of technique failure from patients who lived in neighborhoods where the average education was less than high school. Rural residents in Ontario doesn't seem to impact technique survival, and distance from the center doesn't seem to impact technique survival in Ontario. A previous paper looking at Canada actually found that the greater the distance from the facility, the better the technique survival, but the worse the patient survival. And again, it's patients who are dialyzing far on PD out of necessity who are unwilling to undergo a transfer to hemodialysis when maybe they should have. And again, this is data from the United States, very different. That again, the urban centers, if you look at urban centers and you look at rural centers on the risk of technique failure, in the United States, patients who live in rural centers tend to have higher rates of technique failure. So maybe we're doing something better here in the more rural populations than they're doing in the United States. Distance from the nephrologist. So this is what I was alluding to. If you look at patients who live farther away from a nephrologist, lower rates of technique failure, but higher rates of death. And this is what I sort of was alluding to. You need to look at technique failure and death together. So you wouldn't want to have somebody have better technique failure at the risk of greater rates of death. And this might be, again, people who did not want to transfer to hemodialysis because it would require them to move far from where they're living, and so remained on PD, even though there were signals that they shouldn't have remained on PD. Now moving on to therapy, just food for thought here, CAPD versus APD. There's so much selection bias in why patients choose one over the other that there really isn't any consistent difference, and we call that treatment by indication bias. If you look at the Canadian registry, really no difference in patients who are treated with CAPD and APD. One thing that's interesting is, again, if you look at patients who transfer from hemodialysis to PD versus patients who start on PD, those patients tend to have an increased risk of peritonitis and an increased risk of death. And again, who knows if that's sicker patients starting on hemo or if it's some impact of hemodialysis initially on residual kidney function. And again, this is just showing you again that patients who switch tend to have worse survival on PD than patients who started on PD from the beginning. Icodextrin, there is not very good data on icodextrin. This is one of, I think, 2 randomized control trials of a vast number of patients treated with icodextrin versus glucose. And again, if you look at technique survival, this was in diabetics, they were showing you better technique survival with the use of icodextrin. But I think it's safe to say we will probably never see a randomized control trial of icodextrin versus control on technique survival. So the best we're going to be able to rely on in the future is using observational data and adjusting for observational data as best as we can. What about the neutral pH, low GDP PD solutions on technique survival? The solutions that are marketed as neutral pH and have a lower glucose degradation product content. Again, this was a recent meta-analysis published by David Johnson and Kidney International showing you absolutely no impact of these solutions on technique failure when you do a meta-analysis of randomized controlled trials in the area. So again, these may have some other benefits, but certainly with technique failure is your metric, really no impact. And what about peritoneal membrane transport characteristics? Well, the best done study was probably David Johnson's study, again in Australia, where you look at the different transport categories, and if you look at the risk of technique failure, really there really was no difference in the risk of technique failure across all categories of transport type. So again, what we think about as adverse outcomes on PD is people who are higher transporters. At least in modern day PD therapy, there doesn't seem to be that risk. What about facility factors? So one thing that traditionally has come out as an impact on the risk of technique failure is PD center size. So if you look at Canada's facilities, US, Australia, and Netherlands, the larger the facility, the lower the risk of technique failure. And in some studies, they've actually shown that larger centers have patients who are more likely to adhere to clinical practice guidelines. But again, what is it about larger centers? Is it practices? Is it knowledge? Is it resources? And we really don't know the answer to that. So again, the PDOPPS study will help us really understand what it is about the center variability and technique survival that we can understand and modify. Just to show you in Canada, this is the risk of death on dialysis by province in Canada. And this is the reference province. Unfortunately, Quebec has to be excluded from the analyses because of privacy regulations. But again, if you look at death, there's really no difference in the risk of death very much across facilities in Canada, in provinces, because we probably have very little control over death. As much as doctors we'd like to think we do. But there's probably very little variability here in death on dialysis. But if you look here at provincial variability in technique failure, it's much bigger. And I think why patients leave PD is every bit as much driven by us as it is by the patient. And again, it's really interesting and we need to understand that. This is where Canada sits. Again, very poor data, unadjusted, different definitions of technique failure. But at least here's where Canada sits on the technique failure diagram. Countries like Australia and New Zealand, we all heard about them, great users of home dialysis, but they have much higher rates of technique failure than we do. And again, I'm happy that Australia is participating in the study because maybe they had something to learn from some of the practices in Canada. Interestingly, the United States has slightly better technique survival. And again, that might be because they cherry-pick the very healthiest of patients. But countries like Japan and other countries in Asia tend to have very low technique failure rates. And it'd be helpful to understand their country's practices. So with that in mind, let's talk about the PDOPPS study. So the PDOPPS study objectives, really, as I mentioned, in Canada, sponsored by Baxter Healthcare and CIHR, is really to describe the variation in practice and monitor trends. And what we've done is we've randomly selected dialysis facilities, and within those dialysis facilities, we're randomly selecting patients. And hopefully, if we can collect detailed information among a random sample of facilities and a random sample of patients, we can understand what's going on in the parent population. And we're hopefully going to identify best practices by looking at the variations in practice and outcomes and translate our findings to help improve clinical care. So this is the DOPPS family of programs. Many of you know about the hemodialysis study that's now in several countries. This is the PDOPPS study, and now Australia has just recently joined. But they also have a similar study running in chronic kidney disease. So we're talking today about the PDOPPS study. So really the whole idea is if we collect information on patient demographics, if we collect information on comorbidities, and we collect information on practice patterns, can we look at the impact of these practice patterns on patient outcomes? In the PDOPPS study, our primary outcome is time on PD, but we'll also be looking at mortality, hospitalization, and patient-reported outcomes like quality of life. So it's really to understand practices that maximize time on PD without compromising patient survival. And really a secondary goal is to really develop an infrastructure and forum to promote effective collaborative international clinical research in PD. I mean, the PDOPPS study has brought together international investigators from 5 countries so far, and has really brought us together as a Canadian PD community. And I'm hoping that this community can keep going on, not just in observational studies, but if somebody's got an idea for an interventional study, to provide a vehicle to move that forward. And really the whole goal is to strengthen the evidence base supporting PD treatment. So how is the PDOPPS structure going to look? We're collecting patient-level data. Every patient who starts the study gets a baseline questionnaire, and every 4 months an update on what's happened with the therapy, treatment, hospitalizations, peritonitis, their dialysis access. We're going to always monitor a census of the patient's facility, so we're always going to know how that facility is tracking over time with all of its patients. And then if a patient leaves the therapy, they complete a termination form. At the facility level, each medical director and nurse manager is going to get a survey, so a unit practice survey to the nurse manager, medical director to the physician, and really also, if there's a change in practice in Canada, we might submit a survey to people participating in the study. And this is really the facility level data, the patient level data, and then the only thing that the patient really has to do in the study is complete a questionnaire. And every year, we ask them about a questionnaire. And this year's questionnaire focuses on quality of life, how satisfied they are with the treatment team that delivers their PD, how satisfied they are with PD as a whole, what they'd like to see better, what they think is bad. And so we really get feedback from the patients on how PD is being delivered across the country. And just to give you a study update, we've launched, and several centers in Canada have started. Canada's the leader now, and several centers have started to submit data. We started in October 2013, And early 2014 and onwards, we're hoping to get Australia live. Japan, the questionnaires have just been translated into Japanese, and the UK will hopefully start shortly. And the United States has already recruited some facilities, and they've started entering data. So it's really very exciting to participate in this study. This was the Japanese group. They are so detailed at picking out every little error that you think you've read twice or three times. And it's been really a pleasure to work with them. And this was our recent Japanese, yes, I know, we're the tallest one. This is the recent Japanese steering committee. And so really the milestones here is that we have our country selected. The ISPD we've worked with, they've developed work groups really focusing on the key components of technique failure. We've received peer-reviewed funding, and we started our study selection. And you know, I think in the future, if anybody's got an idea for an ancillary study, like to submit for funding to use PDOPPS data or a study that might expand on PDOPPS, we're in the process now where we really would be interested in hearing about ancillary study ideas, and I'll talk about some at the end. We're starting our data collection, and other countries are really interested in participating. So we've had very promising discussions with Thailand and Colombia who'd like to join the PDOPPS study. And these are our sites across Canada. This is an older diagram of confirmed versus invited. But you know, after today, I'm pleased to say as of 2 hours ago, we've got 100% agreement to join the study. We've submitted RED in 19 facilities, 15 have received full approval, and we've trained 14 sites, 6 sites, and 11 sites have started to submit data. So we're really excited about that. This is the Quebec sites. These were randomly selected sites in Quebec. Dr. Sharon Nesson will be the Jewish General site, Dr. Bissett at Trois-Rivières, Dr. Raymond Hamel at Laval, and Dr. Gastien Rimouski. And these were just randomly selected, and within those sites we'll be randomly selecting patients. And in terms of our clinical research associates, Andrea Rath is overseeing the study as a whole in Canada, with some help from Denise, who's bilingual, so she'll be more the link for the Quebec sites, but they're both working together and will be representing PDOPPS in Canada. In terms of country level funding, I talked about the different countries that have received funding. We're going to be submitting a proposal in New Zealand, hopefully. As I mentioned, Thailand and Colombia are interested in participating. Some of the ancillary proposals that have been funded or are in the process of being funded, in the United States, because there's a huge DOPPS study and a huge PDOPPS study, the question becomes, did patients select PD versus hemo for different reasons, and what are the reasons that patients selected one therapy over another? So there's going to be a questionnaire administered to PD and hemo patients, and this was funded by the Patient-Centered Outcomes Research Institute of the United States, and the PI is Francesca Tentori, and it will really be a study understanding why patients chose one therapy versus another. In the UK, remember I told you that bottleneck that we really don't capture in PDOPPS from catheter insertion to PD? Well, the UK people want to know what's going on in that period. So they've submitted a proposal called Optimizing Early Dialysis Catheter Function. It received initially positive reviews, and we're moving forward to try and develop that, and hopefully that will be funded. And in the United States, Raj Malhotra said, well, if this is a huge repository of clinical information, why don't we establish a biorepository and collect DNA and genetic information on patients? And how does that impact the peritoneal membrane over time? So this was an NIH study that was recently funded called BioPD that I'll talk about. And all sites will be offered participation, and hopefully many sites will decide to join in on the BioPD study. And what the BioPD study is really to understand the differences in peritoneal membrane function between patients, and really to understand if there's a genetic basis to understand the variation in peritoneal membrane function. So people start off with different membranes at the start of PD, and people's membranes change differently over the course of PD. Are there genetic bases to understand why people start off differently, and genetic bases to understand why people change differently? And that's really the main premise of the study. So aim 1 is to look at baseline transport rate, and aim 2 is to look at the change in the membrane's ultrafiltration capacity over time, and how that impacts, how that's impacted by genetic factors. So just to summarize, Technique failure, I think, is variable, and I hope I've demonstrated that to you, and poorly understood, and variability is captured across registries poorly. I think that there's probably many causes in a given patient, and we really don't understand psychosocial causes. And unfortunately, we've had little change in technique survival in Canada in the last 15 years. The exception is patients over the age of 65. And to understand this, we need to understand this complex relationship between facility factors, patient factors, and therapy characteristics that lead to the risk of transfer to hemodialysis. And hopefully we'll be able to understand each of these in modifiable practices that we can implement at facilities to reduce the risk of transfer to hemodialysis. And I hope that we can achieve that through PDOPPS, which really has been a really exciting project to really understand modifiable causes of technique failure. So I just want to thank all the people here who have been working very hard on trying to pull this study together, which has really been an effort among hundreds of people. And thanks very much for your time.